Welcome to the new International HHT Guidelines Education Series with today's topic, Epistaxis and Nosebleed Management. I'm Nicole Schaefer, Director of Professional and Medical Programs for Cure HHT and your moderator for today. Before we begin, I'd like to give you a brief background about the International HHT Guidelines. In 2008, Cure HHT hosted the first International HHT Guidelines Conference, which produced the first internationally recognized HHT guidelines in 2009. 10 years later, Cure HHT hosted the Christopher McMahon Memorial International HHT Guidelines Conference, which was only made possible by a very generous donation from the McMahon family. This event involved 12 months of literature review and topic team discussions with over 60 HHT physicians and patients from 15 countries. The result was the publication of the second International HHT Guidelines in the Annals of Medicine in September 2020. Cure HHT created fact sheets for each topic area, along with the guidelines recommendations, all of which have been bound in this comprehensive guide to managing your HHT. We are providing the first copy of this guide complimentary to all HHT patients and providers. If you haven't received your copy yet, but would like one, please complete the Join Us form on our website. We will post the link in the Zoom chat. And if you ever have any questions related to HHT, center referrals, or an event taking place, please contact the Cure HHT office either by email or phone. This information is also listed on our website at www.curehht.org. Now, I would like to introduce our speakers. Dr. Jay Piccirillo is an otolaryngologist at the Washington University HHT Center of Excellence. And Dr. James Gossage is a pulmonologist and the director of the Augusta University HHT Center of Excellence. Dr. Piccirillo and Dr. Gossage were lead members of the Guidelines Epistaxis group, which recommended the now accepted standards for care for this topic area, making them the perfect speakers for today's conversation. And a special member of our panel today is Heidi Bramlett. She has joined us today to speak about her experience with sclerotherapy and her nosebleed management. At the end of the presentation, all three panelists will be available to answer your questions. So while Dr. Piccirillo pulls up his camera and his slides, let's take our first poll. And the question is, what type of surgical treatments have you experienced? And you can choose as many as apply to you. We'll just give it a few more seconds. And Dr. Piccirillo, here are our results. If you'd like to speak to those.
Good morning, Nicole. Thank you. It's a real pleasure to be here. Yeah, this is sort of what we'd expect. About 50% of you all have had office-based cautery. I assume that's with silver nitrate. About 40% with a laser. That's a little bit more than I would expect. I wonder what Dr. Gossage has to say about that. And then about 30% of you haven't had any treatments. And a few of them had sclerotherapy and then septodermoplasty. So this is great. This is a nice distribution of the type of treatments that patients can get and that I'll be speaking about this morning. Let me get this thing going. Good. How does that look?
Looks great.
Okay. Well, let's go ahead. I'm going to speak about some issues obviously related to nosebleeds. First, I'd like to just describe the three different types of telangiectasias that we see inside the HHT patient's nose. And these are small, isolated telangiectasias. And for people who have these, we call these type 1 telangiectasias. They're the most common. You can also have these more diffuse type of interconnected telangiectasia lesions. We call that type 2. And then finally, type 3 are these large, solitary, almost like atrial venous malformations that Dr. Gossage sees in the lungs and maybe in the brain and other areas. But we can sometimes see these big cherry-like lesions in the nose, and that would be a type 3 telangiectasia. I wanted to share with everyone a picture of a pumper, a nasal arterial pumper that I actually encountered in the office. And you can see that right here. And you can just imagine, it's about the head of an eraser. And you can imagine how much blood that puts out over time. And I'm sure many people on this webinar have experienced a gusher, and that's probably where that's coming from, that type of a pumper. We ask all of our patients in the HHT Center with nosebleeds to complete 2 questionnaires. One is the Epistaxis Severity Questionnaire. It asks questions like, how often do you typically have nosebleeds? How long do they last? I like this question. How would you describe your typical nosebleed? Not typically gushing or pouring, or yes, typically gushing or pouring. And again, that nasal pumper, I think, would be associated with a patient feeling that that's a gusher. And then there's some other questions here. Through great help through the HHT, Cure HHT Foundation, my colleagues here at Washington University were able to create another patient type instrument to measure the physical, functional, and emotional problems with HHT nose bleeding. And the Cure HHT Foundation sent out an email alert to all of its members to participate in this questionnaire survey. And we got 200 people within a week. It was just an amazing outpouring of support for this research that created a new instrument that we think measures the physical, functional, and emotional problems related to nose bleeding better than the other instrument. This figure is the stepwise approach to epistaxis treatment that I and most of my ENT colleagues, and I assume Dr. Gossage and his colleagues think about also, epistaxis severity. So on this figure, we go from mild to moderate to severe epistaxis. And you can see how mild, moderate, and severe are defined. And based on how severe the nosebleed is, the guidelines, expert opinions will then suggest various treatments. So for example, the mild patient, more humidity, lubrication, avoiding some triggers. For the moderate patient, maybe the sclerotherapy, cautery, maybe doxycycline, amicar. And I'm not going to get into these because Dr. Gossage is going to speak in more detail. I will talk a little bit about the surgical treatments like the cautery, dermoplasty, but Dr. Gossage will speak about the drugs. So just kind of keep this overview, this algorithm, as we call it, for treatment of epistaxis based on how severe it is to the patient, mild, moderate, and severe. So let me begin discussion of the different treatments. This first treatment is electrocautery. So it's a cauterization. It's basically the patient's hooked up to a ground and an electrical charge is delivered, in this case by one metal instrument, like almost like a cow prod, if you will, quite frankly, placed into the nose, and the lesion, the telangiectasia, is cauterized. Now, the problem with monopolar, and I don't want to get too technical, is there is an increased risk of perforation or a hole, and that's led to the use of bipolar. And as you can see in the picture, bipolar means 2 tongs are placed into the nose and the electrical current runs between the tongs. So it's a much better way of controlling the electrical current for the treatment of mild to moderate epistaxis. So improved precision, decreased depth of thermal injury. Now the disadvantage is that the thermal conduction doesn't go as deep. So for the bigger lesions, it's a little bit harder, but it's really great. And I'm going to show you a video here of using bipolar cautery. So there's the pumper right there. There it goes. And in comes the bipolar cauterization, 2 tongs, just like tweezers. And it's hooked up to electrical current. And then I push the button on the floor and it sends an electrical current between the 2 tongs, which then cauterizes the pumper. So I got that one, but you'll notice what happens next. If you look carefully, all of a sudden, there's a new one that develops further back, another pumper. And so I go after that with the bipolar electrocautery also. Now, the patient is under general anesthesia. I do not do this in the office. It's way too painful. I suspect some of you, there's another pumper again. I suspect some of you may have had an experience of electrocautery in the office, but it's really hard to deliver the type of anesthesia that would allow this to be done comfortably in the office. The other thing is I like to do these in the operating room to be able to control the airway so there's not a bleeding problem. And then what I did in this patient is follow it up with the application of the sclerotherapy. You'll see a little bit of soap. That's the sclerotherapy drug, Sotradecol, and I've injected it, and that helps seal the area that I just cauterized. Good. So the next type of surgical intervention are the lasers, and there's two or so that I'll describe. The lasers are described by the wavelength of the energy that they deliver. And here again, they're generally done in the operating room, but I suppose some can do it in the office. For moderate to severe epistaxis, if you think of that algorithm, mild, moderate, and severe, the laser photocoagulation is saved for moderate to severe. There is some risk of injury to the patient in the OR. We cover the eyes, and the laser can go places you don't intend to. So you have to make sure, that your physicians are trained in laser, the OR staff is trained. They're not useful for active bleeding because the laser beam gets absorbed by the blood and not by the telangiectasia. So this is KTP laser. There's also neodymium YAG laser. Again, this just refers to the wavelength. They're all lasers. And I know some of my colleagues say, well, the YAG is better than the KTP. And I'm not sure anyone really agrees that one's better than the other. They're all sort of similar. They're all treating moderate to severe epistaxis, and they use a big device that generates a laser beam. Now, a different type of surgical intervention would be this coblation. And coblation delivers energy, almost ultra frequency kind of energy in a bath of salt water, which prevents deeper penetration. That's an advantage. But again, a disadvantage of it is that it still has some of this deep thermal injury potential that you get with all types of surgical interventions. Let me switch to septodermoplasty. This is a procedure where we remove the superficial layer of the lining of the nose, and it's in that layer that the blood vessels, the telangiectasias, sit. So we remove that layer, and then we cover it with a donor skin graft, and it's for more severe or more moderate epistaxis. And this skin graft, which you see here, this kind of yellow pale look, is drawn from the thigh. And the thigh skin is much thicker than the nose skin. And so what it does is it prevents the regrowth of telangiectasias for 2 years or more, and that's an advantage. The disadvantage is we weren't meant to have thigh skin inside our nose. And skin on the outside of our body crusts, the skin sloughs, you can grow hair there, you can have unpleasant, so it takes really almost routine hygiene, almost daily irrigating your nose to keep it clean. And that for some patients can be a real inconvenience. The final procedure I'll mention is the Young's procedure. This is a procedure where the nostrils are closed. Here you see the stitching of the nostril to close it so that no air can get in through the nose. And as a result, it decreases tremendously the amount of nosebleeds. And this is reserved for people with really severe, life-threatening epistaxis, severe epistaxis. I have never done the procedure. It's rarely done. Some doctors do it more. I have just not found that many patients who either have such severe bleeding or have such a bleeding and would agree to have this procedure. It is reversible. Now you lose your nasal function, meaning you can't breathe through your nose. And that's something that really needs to be thought of. So with all of these surgical interventions, there are some complications, and I talked about some of them. They include crusting, boogers, debris, whatever you want to call it. That's what we say, nasal crusting. You can still have bleeding. None of these are cures. Some of them have this perforation I talked about, so a large large hole or this saddle nose means that it's possible that the nose could sink a little bit. Nasal dryness, scarring, crusting are all possible complications. As I said, it's just not a cure. People can still have epistaxis. And so we will continue to recommend nasal hygiene, saline irrigation, things that we think everybody should be doing. So in conclusion, HHT-related epistaxis can vary in magnitude. I showed you that treatment algorithm, mild, moderate, severe. And each patient's treatment should be selected both on how severe it is and tailored to their preferences and what they're seeking in care. A general approach entails this gradual progression in treatments from more conservative measures to more invasive types of measures. And we are doing more research. Dr. Gossage has led trials for this, and I've been fortunate to work with Cure HHT on some trials. And so I want to leave hope and optimism that in the future there'll be even better treatment. So let me stop at that point. I know Dr. Gossage will follow, and then we have a patient with us, and then time for some questions. So thank you very much.
Thank you very much, Dr. Piccirillo. So while Dr. Gossage brings up his video and slides, let's take a second poll. And the question is, have you seen the International HHT Guidelines on the Cure HHT website? Thank you for your responses. And Dr. Gossage, would you like to speak to this?
Well, that's great. So 61% of people have seen them. So we're, of course, looking for 100%, but still, that's pretty good. I'm happy to see that. All right, I assume you can hear me, Nicole, is that right?
Yes, I can hear you.
And let me share my screen. Can you see me, my screen?
We can now.
Okay, great. All right, so I'll be talking about the HHT guidelines, at least the part of them that focus on epistaxis. These are the international guidelines that were recently done in November of 2020 and then published, November of 2019 and then published in September of 2020. So the purpose of these guidelines was to provide new evidence-based consensus recommendation in 6 priority topic areas: nosebleeds, gastrointestinal bleeding, iron and anemia, iron deficiency and anemia, liver vascular malformations, pediatric concerns, and pregnancy and delivery. These were added to the first international guidelines, which were published in 2009. And certain topics were not readdressed in the new guidelines. And you can go to the, for those of you who haven't seen them yet, you can go to the HHT website and look at them. There's a very nice interactive program for reviewing these, and I highly recommend it. I have no conflicts of interest, and I think, as Nicole mentioned, we really want to thank the McMahon family for providing support for these guidelines. And then the overall chair was Marie Fawnin, along with several other people. So this is a picture from the guidelines, and the epistaxis group included 8 people, including myself and Dr. Piccirillo. And you can see some of the people in this picture. There's Dr. Piccirillo. Nicole, can you see my arrow when I do this?
Yes,
you get Dr. Meek, and you've got Dr. Geisthoff, Urban Geisthoff from Germany in the middle. There's me, and other people are in here, but it's a little bit harder to see them.
Actually, we're not seeing your, we're not seeing the photo. There we go. I think you're just delayed.
Okay. So I just switched to methods. Are you seeing that now?
No, but it'll pop up soon.
It's the kind of internet you get when you live out in the country.
Do you want me to bring up the slides and put them up for you?
It might be best if there's this much of a delay.
Okay, yeah, because it still hasn't switched. There, it's on methods. Why don't you go ahead and do that, and I'll bring up your slides in the meantime.
Sounds good. Okay. So these are the overall methods for the guidelines conference. And these guidelines were developed by HHT experts from all over the world, including physicians, geneticists, guidelines methodologists, which is just a way of saying that people that are expert in figuring out how to develop these guidelines. HHT clinical staff, including nurses, and very importantly, patients were an important part of this guidelines. We use what they call the agree to framework and the grade methodology. And I won't get into any details on this, but these are simply the methods that allow us to go from the questions we ask about a particular topic like epistaxis, and then how do we investigate these questions? How do we come to a consensus on what we say about these questions? And that's what the conference was for. And before we had the conference, we generated questions for each area. I think we started with 9 or 10 questions for nosebleeds, and then trimmed that down to 6 important questions. And we did a search of the entire literature, looking for all of the possible papers that might be relevant. And then when we got to the conference, we had a very structured process where we would meet as our subcommittees. So the Epistaxis subcommittee met, and then we talked about the various questions, and then we presented our information, our questions and answers to the group as a whole. I think there were over 50 people in the conference, and then the entire group would vote on these recommendations. And for any recommendation that got at least 80% consensus, so at least 80% of the people that were there, that then ultimately became part of the guidelines. Next slide. Okay, I'm still struggling to get well, anyway, this is good. So just a little bit of background about epistaxis. This is the most common symptom in HHT, seen in at least 90% of people, at least at some point in their life. As you know, the quality of life is commonly affected, and in some cases it can lead to iron deficiency and anemia. If epistaxis is severe, it can affect the quality of life and can even be life-threatening, although that's not too common, fortunately. Symptoms are not always controlled with just moisturization and sometimes ablative therapies. So there are a range of other therapies, including the surgical therapies that Dr. Piccirillo just spoke about, and then some of the medical therapies that I will also address. Next slide. So the consensus conference came up with 10 recommendations, 6 from the current guidelines, and then 4 from the original guidelines from 2009. And it covers a variety of therapies that we'll go through. Next slide. So this is how things are structured. So this is the first recommendation for epistaxis that came out of the guidelines. And it reads, the expert panel recommends that patients with HHT-related epistaxis use moisturizing topical therapies that humidify the nasal mucosa to reduce epistaxis. And hopefully most of you are using this or have at least tried it in the past. This can be something as simple as saline spray. It can be a saline gel such as AYR. Some people use various oils, sesame oil, there's rose geranium oil, which has a little bit of rose geranium oil inside sesame oil. My own preference is for Vaseline and Aquaphor. The longer these substances stay on your nose, the inside of your nose, the longer it will protect the nose. For the most part, saline spray at least, just liquid saline spray, is really gone very quickly. Certainly within an hour or two, it has been absorbed and is gone. Some people actually feel like it dries their nose out, whereas the Vaseline, it can stay there for many hours. And in general, whichever you use, typically people use it when they get up in the morning, before they go to bed at night, and then once or twice in the middle of the day, depending on how bad their nosebleeds are. So each of these recommendations has with it a quality of evidence and a strength of the recommendation. And the quality of evidence can be either low, moderate, or high. And that's based on how good these research studies are. At the low end of the evidence quality would be just a case report, like, we saw a patient with HHT who had this problem, we gave them this, and they felt better. It might be one patient or a couple of patients. And at the high end of it are what we call randomized controlled trials, or RCT, as we've mentioned there. And that's a research study in which people are divided into groups by basically a flip of a coin. It's called randomization, so that randomly they're assigned to one treatment or another. Sometimes that includes a placebo, and that's the best way to do it. That gives us the most correct vision of whether these treatments actually work. But unfortunately, most of our data in HHT, as is true for most rare diseases, is not of the RCT or randomized controlled trial variety. But we did have one RCT here, and it was of a medium size, so the quality of evidence was moderate. Strength of the recommendation was strong. You can see the agreement of 98 and 100%, and that just refers to 98% of the people in the room agreed with this, that it was moderately high quality, and then 100% agreed that this should be a strong recommendation. And the recommendations can be either weak or strong. There's no middle ground for the recommendation. Next slide. For number 2, the expert panel recommends that clinicians consider the use of oral tranexamic acid for the management of epistaxis that does not respond to moisturizing topical therapies. And so just like Dr. Piccirillo had a very nice slide where he showed the severity of epistaxis going from mild to moderate to severe, and he had 3 categories of treatments, that pretty well agrees with how we've set things up in the guidelines here. So at the low end would be your moisturizing topical therapies, which is really first-line therapy. In other words, pretty much everybody with this problem should get this therapy or should try this therapy. And then we move into what I'm going to call the second-line therapies. And that's where the tranexamic acid would come in. And we'll talk about several other of the second-line therapies. So tranexamic acid is something that affects clotting. If we think about clotting, let's say you cut your finger. It bleeds, and then hopefully within a couple of minutes, the bleeding stops as a clot forms. And the formation of that clot is to help stop the bleeding. The body does that on its own. It's a good thing. But then soon after the body sees that clotting, now it says, hey, wait a second, we got clotting going on here. Let's get rid of that clot. So the body is always in this tug and pull of clotting if there's bleeding going on, and if there's clotting going on, getting rid of the clotting. So tranexamic acid is what we call an antifibrinolytic agent. This is an agent that helps the body keep that clot around longer. So when the body starts to try to dissolve that clot, tranexamic acid prevents that from happening. So it doesn't really, some people hear this medication and they're worried about clotting. It doesn't really cause clotting. It just helps stabilize clotting if it occurs. So you wouldn't really expect this to cause a clot in a place where we don't want clots, like the artery of the heart or inside the blood vessels of the lung. I don't really think about it that way. In terms of the quality of the evidence, it was high. There are 2 of these RCTs that showed a benefit to decrease in epistaxis severity, and there was a 92% agreement. So most people thought this was a good thing to do. Strength of the recommendation was strong. Most people agreed with this. Next slide. And in terms of how we deliver this drug, this is a pill. It's unfortunately a fairly good-sized pill. And there are a variety of ways to do this. Some people will start at 500 milligrams twice a day. We don't have that strength here in the United States. Ours is 650 milligrams. And it can be given twice a day, but really it's more of a 3 times a day to 4 times a day drug. So the people that do the best on this drug are people who take it 3 times a day. That's hard for a lot of people to do. So if you've taken this before and you just took it once a day, or I've talked to a lot of people, they try to take it 3 times a day, but they just get it in twice a day and they miss the middle dose. In general, they don't do as well. In terms of contraindications to this drug, we tend not to give it in people who've had recent blood clots, either in the venous side or the arterial side of the circulation. There's some relative contraindications, in other words, instances in which we might like to avoid this drug. These include atrial fibrillation, a heart rhythm problem, which is a common problem in the population, and thrombophilia or procoagulant tendencies, just refer to people that have a tendency to want to develop blood clots in the first place. It's a little bit less clear whether these should be even relative contraindications. Some people, including hematologists, aren't worried about these and give it to people with atrial fibrillation. I'm a little bit more cautious in that regard, but very few people would give it to you if you recently had an actual clot. I feel like this drug works in about 50% of people, sometimes for years and years. For recommendation 3, the expert panel recommends that clinicians should consider ablative therapies for nasal telangiectasias, including laser treatment, radiofrequency or the coblation that Dr. Piccirillo mentioned, electrosurgery, which is electrocautery, and sclerotherapy in patients that have failed to respond to moisturizing topical therapies. So just like the tranexamic acid, this is a second-line therapy. You would almost always want to try the moisturizing therapies first before you moved on to one of these. And you could do either one. Some people might say, I don't really want to do a laser. Let's try the pill. Other people might say, I have trouble taking the pill. Let's try the laser or the sclerotherapy. And both would be a reasonable choice for people who have more moderate nose bleeding or whose nose bleeding hasn't benefited from the humidification. Quality of evidence was moderate. There's one RCT with sclerotherapy and many studies of the ablative therapies like laser and coblation. Agreement was good, but not excellent, 83%. Strength of the recommendation was weak. And I've got to say, I don't really understand this. I don't agree with it. But this was the vote of the group. So everybody, and I'm sure including Dr. Piccirillo, agrees that these treatments work. He spoke about them, he does them, so I know he believes they work. Our ENT believes they work. So why this ended up as a weak, the strength of this recommendation was weak, I don't understand that, because very few ENTs would agree with that. And I think that most center directors will not agree with that either. Anyway, I won't say anything more about this. Dr. Piccirillo covered this pretty nicely. Next slide. Okay, for number 4, the expert panel recommends that clinicians consider the use of systemic anti-angiogenic agents for the management of epistaxis that has failed to respond to moisturizing topical therapies, in other words, first-line therapies, ablative therapies, and/or tranexamic acid, are second-line therapies. So the most commonly used anti-angiogenic therapy is bevacizumab or Avastin. It's an infusion. And it would be uncommon to go straight from moisturizing therapy to Avastin. You would really want to try at least one of the second-line therapies, either a laser or sclerotherapy or tranexamic acid, or maybe even both, before you would move on to this. Quality of the evidence was moderate, and this is based on many research studies, some small, some 5 or 10 patients. The largest study was over 200 patients, and they're pretty consistent in their results. Less epistaxis, improved anemia. The hemoglobin usually goes up by 2 or 3 grams. So if your hemoglobin is 8 to start with, it might go to 10 or 11 or 12. Reduce transfusion requirements and improve quality of life. It's pretty good. It's pretty good treatment. I feel like this helps about 70 to 80% of patients who get it. The strength of the recommendation was strong, and 82% of people agreed with this. Go to the next slide, please. And this is how we give this medication. Again, this is Avastin. It's an intravenous infusion, and we start with an induction course, which typically is a dose of 5 milligrams per kilogram of body weight, every 2 weeks for 6 doses. So this would be given over 3 months. During that period of time, we would monitor for the side effects like high blood pressure or protein in the urine. We can have problems with decreased wound healing because this medication, if we can go back just one slide for a second, Nicole. So these are anti-angiogenic therapies. What that means is anti-angiogenic is against angiogenesis. Angiogenesis is the process by which the body creates new blood vessels. You can go to the next slide. So this drug inhibits that process. It works against that process. And that's how it works on HHT. It either prevents the AVMs and telangiectasias that you have from growing further, and in many cases actually causes these to shrink down in size. So getting back to the wound healing, the way this works is when you have a wound, let's say you have surgery or something like that, the body heals that wound by growing new blood vessels. That's part of the healing process. So if you are getting this medication while you have surgeries, such as hip surgery or gallbladder surgery or something, that would decrease your wound healing. So typically we would stop this drug a month before your surgery and then not restart it for 4 to 6 weeks after your surgery. But that's a very doable thing. Can't be given in pregnancy. So the reason this is a second-line therapy, a third-line therapy, is because it's got more side effects than the other treatments that we've talked about. After you get the induction therapy, then you would move on into a maintenance therapy. And there are many different ways to do this. Some people wait until you start bleeding again and give you another dose. Some people give the hemoglobin drop. Some people give it every 6 months or 4 months or 2 months. So there are many different ways to do this, and I think they all can work. It's a very effective therapy. I've treated about 40 patients with this and have not had many significant side effects. Again, you wouldn't want to do this early on, but it's a very helpful, beneficial therapy for most patients. Next slide. For number 5, the expert panel recommends that clinicians consider a septodermoplasty for people who have failed basically your first and second line therapies. And Dr. Piccirillo already spoke a lot about this. And this is where you would get the skin grafts from the leg. It's a very effective therapy and helps almost everybody, probably 90% or more of people. But after about 2, 3, 4 years, the telangiectasias start growing back and it begins to fail at that time. I recall that about 6% of people had gotten this therapy. Be interested to know what people's experience was with this. And that's about the same experience that I've seen when I see people. We don't do it at Augusta University. It's the only therapy that we don't use. Just because there's so many better therapies and there are a lot of unpleasant side effects that people complain about. Next slide. For number 6, the expert panel recommends that clinicians consider a nasal closure or Young's procedure, again, as a third-line therapy. And Dr. Piccirillo already talked about this. I don't believe anybody in the poll had gotten a nasal closure. We do this and have done it in about 15 patients. It is the most effective therapy available, in my opinion. And more than 95% of people stop bleeding, period. We had one patient who had it and came back and said, you know, I can't smell anymore. My nose stopped bleeding, but I just can't taste my wine. Open me back up. We opened him back up, and then 2 weeks later, he came back and said, you know what? Can't stand the nosebleeds. Close me back up again. And we haven't heard from him in about 3 or 4 years. So it's extremely effective, but it's a considerable treatment. It will, at a minimum, reduce your smell and taste, although it doesn't go away for everybody. Again, very effective, but it's just on the most severe patients that we're doing this. And this is about the last treatment that I recommend. So we're going to try pretty much everything else except the septodermoplasty before we try this. We'll try moisturization therapy, laser, sclerotherapy, drugs like tranexamic acid, Avastin. This is pretty much the last one. But the majority of people who've had it done say, I wish I had this done 4 years ago. These are people who are bleeding an hour a day. They're getting blood transfusions. They're getting iron infusions every couple of weeks. So their life is miserable from nosebleeds. And really, when you're that bad, you're not using your nose to smell anyway, because it's always full of blood clots. So it's just not that big a difference. And if you're considering this or somebody recommends it, I recommend that you talk to a patient. There's always patients who are out there who are willing to talk to you that have had it. And I think it's generally thought of pretty well amongst the people who need it. Next slide. And this is one of the recommendations from the first guidelines that I just wanted to include in there. The other ones were pretty much things we've already talked about. So that the expert panel recommends that the treatment for acute epistaxis, in other words, an ongoing nosebleed that you can't get to stop and that requires intervention, should include packing with material or products that have a low likelihood of causing rebleeding with removal, such as lubricated low-pressure pneumatic packing. I don't like wads of toilet paper or gauze stuck up the nose, because after the blood stops bleeding, clots, and dries, it's going to stick to this packing you put in, and when you pull it out, it's going to tear the clot off, and the bleeding is a good chance it'll start again. So at least if you're going to do some of those things like gauze, at least coat the outside of Vaseline so that it comes out more easily and doesn't trigger the bleeds to occur again. Next slide. And this is just a reminder that there are checklists for each of the guideline topics: nosebleeds, liver vascular malformations, pregnancy. And these are things both to help you and to help you share your condition with your doctor. So I recommend you go to the website, print off these guidelines, and then share them. Next slide. And that's it. And I think it's Heidi next in questions. Is that right, Nicole?
Yes, that is right. So thank you very much, Dr. Gossage and Dr. Piccirillo. That was hugely helpful. And we have had a lot of questions. I see Dr. Piccirillo is behind the scenes answering some of them. So thank you very much for doing that, Dr. Piccirillo. So now we'd like to bring on Heidi Bramlett. So if you would like to start sharing your screen. And while you're doing that, let's take our third poll, which is, have you been to an HHT Center of Excellence? Okay, thank you all for voting. And I'm sharing the results. Heidi, I don't know if you would like to speak to these.
I am so happy that 76% of the people have actually been to an HHT center. You know, when I first went and went through the initial, all the testing, it was very eye-opening of how many organs that can actually be affected by HHT. So for those of you who have not been, I highly recommend you to go and to be treated. I have had HHT my whole life. My mother had it and my brother has it. I started bleeding when I was a baby. For 32 years, I watched my mother being treated. We've gotten great success because it not was known at the time. There was a lot of cordery and a tremendous amount of packing done. In my mid 30s, because I had been anemic my whole life, I was on the verge of congestive heart failure. And I ended up in the hospital with multiple blood transfusions and iron infusions. And at that time, I put together some doctors, Dr. Burkett, Dr. Wally, my ENT, Dr. Ahmed, my hematologist, and they treated me, very aggressively and with great passion. One of the things that I even did was I had a hysterectomy when I was 38 to help control blood loss. And I thank all of them for what they've done and for listening to me after I visit Dr. Piccirillo. Historically, and even now, I do watch, my diet, such as salt intake, no wine. I do continue with all the moisturizing. I have a vaporizer that I use every night. I use the air gel. About 5 years ago, I ran high blood pressure, and they finally put me on some high blood pressure medicine to help relieve the pressure on the capillaries, and that has helped as well. One thing is, like when I've had iron infusions and blood transfusions, I've always suggested, and I've had to be my own advocate, that has to be done slowly, because when IVs like that are put in, it puts a tremendous amount of pressure on capillaries, and I basically almost bleed out more than what they're giving me. So they've learned to give me a slow drip. My brother, was doing some studying, and he discovered the HHT Center, and that's how I learned about it. And that's when, after the series of tests, then I was introduced to Dr. Piccirillo. And I normally have the sclerotherapy done every 3 months, which has given me a quality of life that I never thought that I would have. And I probably would not even be able to work with the amount and the length of the nosebleeds I would have in a day. I am fortunate, to have a managing partner, Mike Clem, that has always been helpful and considered to let me go to all my doctor's appointments and with having nosebleeds at work. The past 18 months, because of COVID, I did not have the sclerotherapy. And my nosebleeds just kept getting worse and worse, and I was having to have more and more iron infusions. COVID confirmed what I already knew, that the sclerotherapy procedure that Dr. Piccirillo does on me has been a game changer in my life. I can function more like a normal person, and I can be involved. I don't have to worry about the when and how many times I'm going to bleed, like at work or at a board meeting or at the Philharmonic. It's if I'm going to bleed. And the difference between when and how many times my nose is going to bleed versus if is life-changing. I cannot thank Dr. Piccirillo enough for giving me the opportunity by doing the sclerotherapy on me and making other suggestions also along the way. With being able to have the therapy done, I can be involved, you know, rather than someone who doesn't want to leave the house or can't leave the house because of the nosebleeds, and also just the embarrassment of the nosebleeds. So I want to thank Dr. Piccirillo for making a difference not only in my life, in my world, but also in the HHT world with your research and the sclerotherapy. This is just a brief synopsis, and I appreciate the opportunity to be able to speak here. So thank you.
Well, Heidi, thank you very much. We truly appreciate you sharing your story and being vulnerable with us today. And if Dr. Gossage and Dr. Piccirillo and then Heidi, if you want to come back, put your videos on, and we will go ahead and start the question and answer period. And obviously we are close to our 1 hour and we do have a lot of questions. So I'm assuming everybody will hang out with us because we are going to continue so that we can answer most of your questions. So Dr. Piccirillo, I know that you answered several people, but we must have had 6 people ask us about petroleum-based moisturizers and Aquaphor and risks of going into lungs. So if you could just maybe speak to that for the entire group, I think it would be appreciated.
Sure, and I want Jim's opinion as a pulmonologist. So the bottom line is I don't really worry about it. I understand there's a theoretical concern about petroleum in the lungs. And again, Dr. Gossage can speak to that, but I've never experienced in any of my patients. I don't really think it's a major concern. Jim, what do you think?
You're muted, Jim.
Agree 100%. I tell patients that just a very light coating is all you need. And as long as you don't pack your nose with Vaseline, you'll be okay.
Okay, great. Well, thank you. It's just we had so many people ask that question. I just needed to put it out there. So
Nicole,
Todd,
may I make one comment?
sure. Go ahead.
I lost you there. So one thing I hear from a lot of patients is concern about cautery. So I wanted to say a couple things about cautery. The term cautery includes a lot of stuff. It includes chemical cautery, which for the most part we don't like. I suspect Dr. Piccirillo agrees with that. And then we've got electrocautery, laser, those are all kinds of cautery. And I not uncommonly see patients who've had a cautery in the office, maybe with silver nitrate or an electrocautery without any kind of significant anesthesia, and it was very painful for them. And then they're now very against cautery. And I want to just let people know that just because you've had one bad experience with cautery, most likely from somebody who was not an ENT at an HHT center, cautery can in general be done pretty painlessly if it's done right by somebody who knows what they're doing. And that's why we recommend going to an HHT center, just because of one bad experience.
Okay, well, thank you for that clarification. So we have had, Haley is asking about tranexamic acid and wondering how long someone would be trying that drug or be able to stay on that.
I'm going to try switching over to my phone because I think my internet connection is not that good.
Okay.
So for tranexamic acid, you can be in that for a very long time. It takes typically about a month to kick in. If you haven't had a benefit after a month, you're probably not going to get a benefit. But I've had people on that for 4, 5, 6, 7 years. It really has very few side effects, no long-term side effects that we're aware of.
And Kathy is asking, are there any negative side effects to the tranexamic acid for someone with pulmonary arterial hypertension?
No, not for pulmonary arterial hypertension, at least as far as we're aware.
Okay. So our next question comes from Todd, and he's asking, are there any topical anti-angiogenic drugs that might help directly applying to the nose?
Well, we did a research study, the nose study, several years ago, and we compared tranexamic acid to topical Avastin, and these were all topical sprays, and none of them were any better than just saline. Now, one caveat about that is that I believe we probably used too low of a dose of the Avastin spray. And I have several people who use Avastin spray every 6 months and tell me that it really works well for them. But that's at basically full strength, whereas we used a much smaller dose for the nose study. So I think it works, but that's that low level case report kind of data. The only high level data we have on that, the randomized controlled study, it was not effective, but I suspect that's because the dose was too low. Now, doxycycline, well, that's not a topical agent, so I won't talk about that quite yet.
Okay.
Nicole, if you could ask Jay a question or two, I'm going to try to switch over to my telephone.
Yep. Well, the next one is for Jay, and it's asking, does sclerotherapy alone require general anesthesia?
No, not at all. As a matter of fact, all of my sclerotherapy is done outpatient with just local anesthesia to the nose. It can be done in the operating room with general, and I've done that for many years, but no, it's an outpatient. It's like going to the dentist.
Okay. And Heidi, would you want to talk a little bit to how that procedure is, since you've gone through that several times?
Yes, it's really, the very first time Dr. Piccirillo did take me to the OR, but after that, I just go in about every 3 months, and he puts some medicine to numb the nostrils, and he goes in and he's in there working, and after he hits several of the big telangiectasias, he's done, and I'm able to go home, and it's nice just to be able to come and go like that, and not requiring a stay in the hospital or anything like that. And I do highly recommend it.
And Dr. Piccirillo, it's not a question that anyone's asked, but it's one that I know is a bit of an issue, is sclerotherapy is not readily available at every center. Would you want to talk about that just a little bit?
Well, it's a discouragement and disappointment of mine that I can't get more of my colleagues to take up the procedure. You're right, Nicole. So it's very limited. Reasons for that? Well, we use special syringes. You've got to order the medication. It's just something that the docs aren't doing to the extent that I would hope they would. And so I don't know how else to answer that, Nicole. I try.
Well,
I go to my national meetings. I talk about it.
Yeah. Well, and I know that I know a lot of people who travel to Missouri just to see you for that procedure as well. Now, do they do it?
Yeah, Nicole, working with your organization as we bring on new HHT centers of excellence, your group has been great to get me involved with the ENT people for that very reason. So I appreciate that.
Yeah. And I think you're on our new Center of Excellence committee, so you'll have a more vibrant role in that going forward for sure. Dr. Gossage, is sclerotherapy something that's offered in Augusta?
Oh, yeah. I think that the way I look at it is only the very finest of HHT ENT physicians use sclerotherapy. So it's really for just those very special docs like Jay and Dr. Whitehouse. So
sounds good. So Dr. Gossage, this one is for you. It's from Bob, and he's asking, Why is anti-angiogenesis recommendation strong at 82% when surgery was not strong at 94%?
That is one of the inexplicable. So voting, this is a consensus process where people, human beings, vote. It's just like voting for president. People vote for whoever they want based on obscure reasons. And so someone may vote against it or for it. I can't explain it, but that's just how it worked out. It's just
Jim,
someone may have a little bit of a bias against it. Yeah.
Jim, don't you think that there really weren't enough high quality, that would be randomized clinical trial studies? And I think some of our colleagues were really sticking to the rules that unless there's high quality studies, we can't give it a strong endorsement.
Well, that would make sense, but that wasn't. If you look at the actual recommendations, there were some things that both had moderate, like sclerotherapy, like Young's and septodermoplasty, basically had exactly the same amount of literature. A handful of case series, and one was given strong and one was given weak.
Yeah.
So it doesn't seem to, and in some things that had the same level of evidence, they could have a high vote by the audience or a low vote in the next thing. So it's not fully objective, but it's the best we have.
Sure.
And so we had a couple of questions asking about how to help children manage nosebleeds. And I think specifically it's two individuals stated a 12-year-old. So would you like to speak to that?
Yeah, and I would just say in general, we don't really do a whole lot different for the 12-year-olds, adolescents, except maybe just be a little bit more conservative in what we do and not quite as aggressive as we will with an adult.
Okay.
Yeah, I agree with that.
Okay. So we have an individual, Dennis, is saying that he's on warfarin for clots and a heart valve replacement, and wondering how much is that affecting his HHT, specifically like the nosebleeds, and what would your recommendation be for people that do need to be on blood thinners?
I can take that one. So it's variable. In general, when, let's say you've got somebody with HHT and has nosebleeds, and then has to go on a blood thinner, and it could be warfarin, it could be something like Eliquis. And when they're started on the blood thinner, in general, about 50 to 70% of the time, the nosebleeds get worse. Could be a little bit worse, could be a lot worse. But that also means that about 30 to 50% of the time, they don't get worse. So it doesn't get worse for everybody. So if you have to be on a blood thinner for an important reason, let's say you've had a stroke or you've had a heart attack or something, you had a blood clot in your lungs, then we'll just work hard with you if the nosebleeds get worse to fix them. With all the things we've been talking about, our options. Sometimes we might need to do a little bit more of that or use multiple things to get a person better. But we can get almost everybody better, even though they're on blood thinners, with the tools that Jay and I have been talking about.
So I have a couple of individuals that have asked about medications that were not mentioned. Well, really, estrogen, estriol. Would you mind speaking to that a little bit? And do you think they have any impact on nosebleeds?
Sure. So estrogen, let's just say estrogen pills, high dose estrogen pills, there's no high level data for them, but there is some of that moderate quality data that's out there that suggests it does work. But estrogens have serious side effects, cancer risks, blood clots. So I've got a few people who are still on estrogen just because they've been on it for a long time, especially women, and they need it for other reasons. But I've had some men who've taken estrogen because it helped them. But we've got so much better treatments nowadays that I haven't started somebody on an estrogen in years. So estrogen pills, there are much better treatments than those. Now, topical estrogens like estriol ointment, I think there is some moderate quality data to suggest that estriol ointment works. And when we did the nose study, we used estriol, was one of the 4 treatments that we used, but it was as a spray, not an ointment. And it was no better than saline spray. So adding the estriol powder to the saline spray was no better than just the saline spray by itself. So I do have patients who continue to use that from early in my career. They feel like it helps them, but that's on estrogen, on the estriol ointment. So I think probably spray doesn't do anything. The problem with sprays is they go in there, and most of the sprays, and we can get Jay's opinion about this, most of the sprays, if it's just a standard liquid spray like saline, it's just going down the back of the throat and it's gone very shortly thereafter. And I know Dr. Piccirillo is working on some things that are in a kind of a gel-like that adheres to the mucosa. Maybe he want to comment on that.
Yeah, exactly. Yeah, I agree with Jim about the saline spray. It probably just goes down the back of your throat. But we did complete a study where we used what's called a thermosensitive gel to carry a product, timolol, which is a heart drug, to decrease bleeding. The thermosensitive gel is a lot like men's shaving cream. You know, you spray it on, you put it on, and then it gets all kind of bubbly with the heat of the body. And so the same thing happens inside the nose. The HHT patients in our trial squirted the thermosensitive gel in the nose, and it kind of expanded almost like crazy glue. And they loved it. And we were unable to show, both groups of patients, those who got the thermosensitive gel with the timolol drug, and those who got the thermosensitive gel with the placebo, the fake timolol, both groups did really well. They loved it. In fact, the timolol group did really no better than the thermosensitive gel alone. And so the research pharmacy that we worked with is trying to reformulate it so it has longer shelf life to give it commercial applicability. Right now, it's just a research drug, but that's something we're working on. Thermosensitive gel, it's called.
Okay. And I think this just also emphasizes that we have clinical trials going on at various HHT centers. We have multi-center trials going on. And so it's just important to stay connected with Cure HHT so you're aware of some of these opportunities to try other therapies. So Anne is asking how long a patient can safely be on Avastin. This person has had many of the procedures that we talked about today, and they currently have a septal perforation, and she's curious about Avastin. And
so the quick answer is we don't really know. I've had patients who have been on it for maybe 4, 5, 6 years now. I haven't really seen people, it's not like some drugs where you're on it for a long time, you get leukemia or cancer or something. We haven't really seen that with this drug.
okay.
There are definitely some people who take it and after they have a good initial response, then after 2 or 3 years, the effect seems to wear off. As happens with many drugs. We see that sometimes with the tranexamic acid and some other drugs, they get an initial response and then it wears off. But I'm not aware of any data that you can develop more problems the longer you're on it. But in truth, we just don't have enough data on people who've been on it for 10 or 15 years to really know. So.
And Gary is asking if there's a major risk of blood clots with Avastin.
Risk is about 2% for blood clots. In patients with HHT, the risk is higher for cancer patients. which is what Avastin was originally developed for. So in general, we wouldn't put somebody on Avastin who had a history of blood clots unless they were already on a blood thinner. So I've got several people who have had blood clots and they're on blood thinner for that reason. And then we put them on Avastin, and that's okay, because the blood thinners will prevent them from getting blood clots on the Avastin, at least we think it will. But the blood thinners will not prevent the Avastin from having its beneficial effect on the GI bleeds and the nosebleeds.
We've also just had, it looks like some conversation amongst the attendees, but in that came up the PATH HHT study and the impact that that may have with pomalidomide on nosebleeds. Would either of you want to speak to that?
Along what, in what?
What is the study? What would pomalidomide's impact be on nosebleeds? Maybe why
Gotcha.
should people consider, I think there's 12 HHT centers recruiting sites and some more is coming on. So
Yeah, so the PATH study, PATH study, is a study of pomalidomide, which is an anti-angiogenic drug like thalidomide. And we have some evidence, decent evidence, that thalidomide helps people with nosebleeds and GI bleeding. And pomalidomide is a newer generation version of that we think has less side effects, although that still needs to be sorted out. And that's one of the main reasons for the study, is to see what exactly are the side effects of pomalidomide in HHT patients. So this would be an anti-angiogenic drug, a third-line agent. And if you have tried other things, various ablative therapies, you've tried tranexamic acid and are still struggling with nosebleeds, then this might be a reasonable study to try. It's an expensive medication, and it would be hard to get it approved through your insurance company, but you could get it for free in the PATH study.
okay.
I do
Great.
see, Nicole, a lot of questions about doxycycline on the
Yes.
feed.
Mhm.
So I'd actually meant to put a slide in there, but forgot. So doxycycline is an antibiotic. It has other properties. It's also a metalloproteinase inhibitor, which means that we think it helps stabilize the wall of the blood vessel. It may help shrink AVMs down. And there's a couple of studies, some of them not fully published yet, that suggest that it can be helpful. I've used this in a lot of patients and feel like about 50% of patients get a benefit from this drug. Similar to tranexamic acid, it works in a different way. It may be anti-angiogenic, but we just don't know that yet. But I've had some people have tremendous benefit from it and people who've had no benefit from it. Low side effects. We give it at a sub-antibiotic dose, at least to start with. I've had people on this for 3-4 years without any antibiotic resistance problems. So I think it's something that is helpful, but really needs more research. And there are 2 studies, these randomized controlled trials, that are underway right now. One from UCLA just finished, but I don't think the results aren't in yet, are they, Nicole? Any word on that yet?
No, I don't think so.
And the Toronto study is doing the Toronto Center is doing a study on that also, and that's not finished yet. So I think we'll have some good information in the next 2 years about that.
Okay, fantastic. So a question about the rose geranium oil, and asking if it needs to be diluted in a carrier oil before using in the nose. Would either of you like to speak to that?
No comment.
Not a believer? Yeah. Do you all use that there, Jim?
Well, I've tried it more in a couple of patients that came in and had heard about it and asked me if I would prescribe it, and it's easy enough to do, safe enough to do. I've done it. Some have noted the benefits, and there's one very small study that suggests a benefit. I think it's a harmless medicine, again, as long as you don't just drain it into your nose and then suck it into your lungs. So.
Okay. Yeah.
But it's not one of my top line therapies is the bottom line.
Okay. So we have Bob asking if anti-angiogenesis drugs contraindicated in patients with type 2 diabetes when blood sugars are well controlled due to the wound healing concerns.
It's a good question. Haven't heard that one before. Certainly, if you had somebody with diabetes who had active wounds, let's say ulcers on the feet, regardless of how well the blood sugar was controlled, we wouldn't want to use it. But if the diabetes was well controlled and you had no wounds, then I think it would be a reasonable drug to try with good monitoring.
Okay. Gary is asking if there's any chance that doxycycline can cause GI bleeding.
I have not seen that as a complication for my patients. I can't imagine how it would do that. So my gut feeling is no.
I agree.
Okay. And we had some questions come in prior to this event. And one of them, which I think Heidi can also speak to, is just how do the centers work with local physicians if a person was to travel to a center of excellence for screening and care, but then go back home? How does that work?
My experience has been, once I've had, a session with Dr. Piccirillo, or, I've gone through my, a couple of years with Dr. Chakanala, I glean from all their information, and my local doctors, I always keep them updated, and they want to be updated because they want to, follow and be supportive and do exactly what needs to be done. I think, the doctors are really good probably to talk back and forth. So on my end, I have been really fortunate that the communication has been fantastic.
And from your perspectives, Jim and Jay, how do you coordinate with local physicians for your patients?
Well, yeah, as a national referral center, we just have an obligation to keep in touch with the local physicians. And so that's just something that we do. Maybe not as good as we should, but we definitely recognize the importance of keeping the local physicians involved, because after all, they do the majority of the care, I think, for so many of the HHT patients.
Yeah, I agree. And now with the electronic medical records, it's actually pretty easy. I see a patient, I prepare their note. There's a little box I can check, and I can just automatically send it to all the doctors that they're involved with. So it's never been easier to keep that communication going. And for patients who are having more trouble, especially, I just keep an open line with the hematologists, especially. So those are the ones giving the iron and the blood, and typically the ones who are giving the Avastin infusions back home. So I spend a lot of time talking to local hematologists to sort these issues out and make sure we get them on a good regimen. And they're typically hematologists especially, are very happy to help with these things.
Okay. And then let's just make this our last question. Raj has asked, is there anything that they can do to reduce the growth of telangiectasias? And I would take that beyond just the patient, but what is the future research? What are some of the things that we're looking at as drug therapies and treatments for people with nosebleeds, because obviously this is one of the largest symptoms, and it definitely can have major quality of life implications.
You're talking about skin telangiectasias, like the lips and the
No,
fingers?
I'm saying for the nose, or for GI, or just for telangiectasias, period, where people are bleeding, they're anemic, they, you know, just all the surgical treatments aren't working. You know, is there any, what's on the horizon? What kind of research is currently going on that would provide some hope to those that are participating today?
Well, we've got all the anti-angiogenic drugs that we've talked about. Those, we believe, decrease the telangiectasias. In fact, we just about got a paper that's going to come out very soon of a man who took pazopanib for 5 years, and I took pictures of his face at the beginning of the study, and then earlier this year, and his telangiectasias, he really had a lot of large, obvious telangiectasias, and you can hardly even tell he's got telangiectasias anymore. It's a very impressive decrease. So that's several years, and they didn't go away right away. It really took several years for these things to shrink down. So I think the anti-angiogenics can do that, and maybe even tranexamic acid we think might have some anti-angiogenic properties. There are other anti-angiogenic drugs that are in the pipeline for research. There are companies that are, I've talked with a couple companies that are working on drugs that may have anti-angiogenic properties that they're looking at to study in HHT. So I think there's more and more stuff coming out there. Jay, anything from your perspective?
No, I can't add anything to what you said. Dr. Gossage is on the front line of what's happening on the anti-angiogenic front. It's great.
Someone mentioned about the face and whatnot. I've actually had a couple of big telangiectasias that came up on my lip, and Dr. Piccirillo is sclerosing on them, and they were quite big and were bleeding quite a bit, and within 2 weeks they disappeared, and I have no scarring on my lips at all. And he just did my thumb on Tuesday.
Well, it sounds like we should all be traveling to WashU and visiting Dr. Piccirillo. Well,
And have to double your clinics, Jay.
Well, on behalf of everyone here at Cure HHT, I want to thank you all for attending today's webinar and just for staying connected with us. Here at Cure HHT, we are here for you as the only patient advocacy organization funding HHT research, providing education materials to patients and providers, advocating for the disease, and expanding treatment centers around the world. And so we're extremely grateful for today's speakers and for their very thorough overview of treatments and nosebleed management, and for the McMahon family's commitment to pay it forward so that future generations have more effective treatments and ultimately a cure for HHT. Because without their financial support, the Guidelines Conference would not have been possible. So remember, if you haven't received your complimentary copy of the Comprehensive Guide to Managing HHT, let us know by completing the short survey that'll pop up on your screen at the end of this webinar. This is only one topic in the International Guidelines Education Series. It is the second to last topic, so all of the others are available as recordings in our resource library. The final topic, diagnosis and genetic testing, will be on Thursday, June 24th. And lastly, I want to remind everyone that June is HHT Awareness Month, and it's the Foundation's 30th anniversary. There will be events and activities all month long, from the virtual walk, which is going on now, called Strides for Strength, to more guideline webinars. And on June 23rd, which is Global HHT Awareness Day, we will be celebrating Cure HHT's 30th anniversary celebration, and we invite all to attend. It is free of charge. You just need to register, which you can do online on our website at curehht.org. So keep visiting our website and social media channels for updates on these and many more activities. Again, I want to thank Dr. Piccirillo, Dr. Gossage, and Heidi for volunteering their time today. This program has been recorded and will be posted on our website. We truly appreciate your participation and enjoy the rest of your weekend. Bye, everybody.
Bye, everyone.
Thank you.